Hello, everyone, and welcome. Today, we're going to be focusing on Chapter 7, all about depressive and bipolar disorders. Before we go into the DSM 5 diagnostic criteria of depressive and bipolar disorders and talk about the way in which we can view these disorders and treat them, let's first talk about what defines depressive and bipolar disorders. Depression is a low, sad state that's marked by significant levels of sadness, lack of energy, low self worth, poor body image, guilt, shame, or related symptoms. Mania are states or episodes of euphoria or frenzied activity in which people may have an exaggerated belief the world is theirs for the taking. Depressive disorders are groups of disorder that are marked by unipolar depression. Unipolar depression is depression without a history of mania. And finally, we have bipolar disorder. This is a disorder that's marked by alternating or intermixed periods of mania and depression. First, let's look at unipolar depression. So, how common is unipolar depression? It's estimated that about 8% of US adults suffer from severe unipolar depression in any given year, and 5% suffer from mild forms. Unipolar depression is actually the second most diagnosed mental illness in the United States behind anxiety. 20% of adults experience unipolar depression at some point of their lifetime. So that lifetime prevalence breaks down to 26% of women and 12% of men. The average onset is age 19, and there's higher rates among chronically ill elderly people. Among children, the prevalence is similar among boys and girls. Approximately 85% of people with unipolar depression recover, some even without treatment, and around half will experience another episode later in their lives. So, what are the symptoms of depressive disorders? Well, they can be classified into the symptoms you see on your screen. So, emotional symptoms would include things like feeling miserable or empty or humiliated, and they experience little pleasure in life. Motivational symptoms is where an individual will lack drive, initiative, and spontaneity. And about 16 and 15% of those with severe depression will die by suicide. Behavioral symptoms can include less activity and less productivity. Cognitive symptoms can include holding a negative view of themselves, blaming themselves for unfortunate events, and being pessimistic. Physical symptoms can include things like headaches, dizzy spells, or overall general body pain. And these symptoms will vary from person to person. The DSM 5 lists several types of depressive disorders. Major depressive disorder is a severe pattern of depression that is disabling and is not caused by factors such as substances or a general medical condition. Persistent depressive disorder is a chronic form of unipolar depression that's marked by depression. Premenstrual dysphoric disorder is a disorder marked by repeated episodes of significant depression and related symptoms during the week before menstruation. Let's look at major depressive episodes. In order to qualify for a major depressive episode under the DSM 5, for a 2 week period, the person must display an increased depressed mood for the majority of each day and or a decrease in enjoyment or interest across most activities for the majority of each day. For the same 2 weeks, the person also must experience 3 or 4 of these symptoms. So, weight changes, appetite changes, insomnia or hypersomnia, agitation or decrease in motor activity, fatigue, lethargy, feeling of worthlessness, excessive guilt, and a reduction in concentration or decisiveness. There also must be a repeated focus on death or suicide, a suicide plan, or a suicide attempt, and it must cause significant distress or impairment in one's life. Major depressive disorder is where you will find that there's a presence of a major depressive episode. And under a major depressive episode, typically you'll find that criteria 1 and criteria 2 are met. So, criteria 1 and criteria 2 is for that 2 week period. There must also not be a pattern of mania or hypomania. Under persistent depressive disorder, the person must experience the symptoms of major or mild depression for at least 2 years. And during that 2 year period, the symptoms can't be absent for more than 2 months at a time. Also, there's no history of mania or hypomania, and it causes significant distress or impairment in the functioning of one's life. We also have dysthymic disorder, and these symptoms are mild but chronic, where depression is longer lasting but less disabling. And again, those consistent symptoms last for at least 2 years. When dysthymic disorder leads to major depressive disorder, the sequence is called double depression. We also have postpartum or peripartum depression. These symptoms may last up to a year or more and can include the things you see on your screen. It also has an impact on the mother infant relationship and child well being. Typically, the causes can be a genetic predisposition, triggered by hormonal changes after childbirth, and psychological and social changes. So, how do we treat postpartum depression? There are many self help groups that are out there that help to support mothers who are experiencing postpartum depression. Also, for some mothers, antidepressants can be helpful in a short term or even a long term state. Also, utilizing CBT, interpersonal psychotherapy, or a combination of these therapies. Treatment is most often sought for if it becomes debilitating enough that people consistently point it out to the mother. The mother says something to their primary care physician or gynecologist, midwife, or doula, and they make the suggestion to go seek support. Or for many parents, they have thoughts of harming their child or they have no interest in bonding with their child. Those are sort of the wake up calls for them to go seek help. But treatment can be helpful for those who seek it. So, what causes unipolar depression? From a biological view, a lot of these are based on genetic factors, biochemical factors, brain circuits, and the immune system. So, whenever there's an imbalance in neurotransmitters or hormones, where there's an overstimulation or an underproduction of neurotransmitters and hormones, that can certainly cause issues and concerns with unipolar depression. Furthermore, if you have a family history of depression, depending on how far back you go in your genealogy, the more likely you are to have at least a depressive episode. In addition, the more closely tied the genealogy is, therefore, for you could be your parents and or your grandparents. The more closely related you are to the person who has depression, the higher the likelihood that you can in fact develop depression. So what we see here is comparing depressive and bipolar disorders. So we've talked about major depressive disorder, also known as MDD, and persistent depressive disorder, or PDD. We're going to be talking shortly about bipolar 1, bipolar 2, and cycle, I always butcher this word, excuse me, cyclomythic disorder. So I encourage you to pause this video to take a look at the prevalence within a year, the female to male ratio, typical age of onset, prevalence, and percentage receiving treatment. And when you're ready, continue on. So from continuing and looking at a biological view, these biochemical factors are certainly going to be important to look at. So typically there's going to be low activity of two of the neurotransmitters, serotonin and norepinephrine. So these early studies, especially in the 1950s, they looked at high blood pressure and antidepressant drugs. So the medication for high blood pressure were found to cause depression. Some lowered serotonin, whereas others lowered norepinephrine. But later, neurotransmitter interaction research showed that truly effective antidepressant medications, which relieve depression by increasing serotonin and norepinephrine, confirmed the role of neurotransmitters. Depression likely involves not just serotonin or norepinephrine, but there's a complication interaction at work and other neurotransmitters may be involved. In addition, there could also be additional hormones, and the hypothalamic pituitary adrenal pathway may also play a role in this. So, there were people who had depression who've been found to have abnormal melatonin secretion. This is also called Dracula's hormone. Other researchers are investigating deficiencies of important proteins within neurons that can be tied to depression. When we look at the brain circuitry, there could be a dysfunction. Researchers believe that the brain circuit involved in unipolar depression includes the prefrontal cortex, hippocampus, amygdala, and the cingulate, among other structures. These researchers have determined that emotional reactions of various kinds are tied to these brain circuits. These networks of brain circuits work together, triggering each other into action and producing a particular kind of emotional reaction. It appears that one circuit is tied to generalized anxiety disorder, another to panic disorder, and yet another to obsessive compulsive disorder. And something we need to think about is that although research is far from complete, a circuit responsible for unipolar depression has begun to emerge. And likely, the brain areas in the circuit inside the prefrontal cortex, hippocampus, amygdala, and the Brodmann area 25 are responsible for unipolar depression. There's also been a study when it comes to football injuries and depression. So they looked at the NFL, I should say, worked on a research study with 2,500 retired NFL players. And they found that those suffered 3 concussions during their careers were 3 times more likely later to develop a depressive disorder than those who had no concussions. And if you've ever watched football, it's very likely that someone doesn't have at least 1 concussion in their career. Players who experienced 1 or 2 concussions were 1.5 times more likely than other players to develop a depressive disorder. And approximately 26% of all former professional football players have experienced 3 or more concussions. As we talked earlier, your immune system also plays a role. So, the immune system is the body's network of activities and cells that fight off bacteria and other foreign invaders. When stressed, the immune system may become dysregulated, which some believe may help produce depression. There's also a higher incidence of things like migraine, IBS, chronic fatigue, rheumatoid arthritis, also known as RA, and other illnesses that can cause this CPR production and body inflammation. The support for this explanation is is circumstantial, but it is compelling because when stressed, the immune system becomes dysregulated, which some researchers believe may help produce depression. Let's look at a psychological view. First, we'll look at psychodynamic. So, Freud and Abrams said that when some people experience real or imagined losses, this is known as a symbolic loss, that it can lead to unipolar depression. For these for the symbolic loss, it can be regression to an earlier stage of development and introjection of feelings for the lost object and eventually becoming depressed. So, there is something that can occur with this, and it can lead to essentially grief. When a loved one dies, there's an unconscious process that begins, and the mourner can regress to this oral stage and experience introjection, which is a direct feeling for the loved one onto itself. For most people, introjection is temporary. For some, grief can worsen over time. If grief is severe and long lasting, that's where depression results. Those with oral stage issues, where they have these unmet or excessively met needs, are at greater risk for developing depression. Instead of an actual loss, some people will experience that symbolic or imagined loss instead. Object relations theorists say that depression results when people's relationships leave them feeling unsafe and insecure, especially in their early life. So, what are some strengths and limitations of the psychodynamic view? So, the strengths are that there's general research report, especially when looking at depression triggering major losses or being triggered by, major losses. And the earlier the losses that occur in life sets the stage for depression at a later state in life. And depression after loss related to poorly met childhood needs are common, especially in adults. Some limitations are that early losses and inadequate parenting sometimes leads to depression, but may not be responsible for development of the disorder. There might be other issues and concerns or other experiences that lead to this. Many research findings have been inconsistent, and certain features of the model are nearly impossible to test because you're going solely on someone's recollection of information which may not be accurate. Now we look at a cognitive behavioral view. The cognitive behavioral view says that depression results from problematic behaviors and dysfunctional thinking. So, some of the theoretical perspectives look at a behavioral dimension, negative thinking, and complex cognitive and behavioral factor interplay. So, they look at the types of behaviors that lead people to engage in possible depressive issues like isolation and withdrawing from others. They look at the negative thinking patterns, also known as cognitive distortions. Then they look at how this interplay between the cognitive distortions and the behavioral patterns can affect how someone experiences their life, which may lead to depression. Something to think about too is that for many, texting is the leading communication medium for people. And there are research that suggests that there might be a negative affective relationship that occurs when someone texts instead of calling someone, using things like Zoom or FaceTime to virtually see someone or seeing them in person. Turkle said that texting can lead to avoidance of direct communication or possible confrontations, reduction of emotional connections, misunderstanding, relationship damage, and broader feelings of overall stress and unhappiness. Something to think too is that the average 18 to 25-year-old sends and receives a total of 128 texts a day. Surveys suggest that people often fail to fully attend to their current activities as they struggle to juggle their text conversations. So, with all of these in mind, what do you think? Do you think that texting, even though it is a leading communication, is actually causing more stress and more harm, therefore leading to possible depressive symptoms? So we looked at that cognitive portion. Now we can expand more on the behavioral dimension. So, for that behavioral dimension, what ends up happening is that depression can result from changes in the rewards and punishments that people receive in their lives. A psychologist named Lewinson suggested that positive rewards in life dwindle for some people, leading them to perform fewer and fewer constructive behaviors, which can then lead them to spiral towards depression. Other research supports the relationship between the number of rewards received and the presence or absence of depression. Social rewards are especially important because if you are not receiving social rewards, you are less likely to engage in things. And by not engaging in things, that can lead to withdrawing and isolation and future feelings of hopelessness and helplessness, which lead to depression. Then we talk about negative thinking. This is again under the cognitive behavioral realm, looked at as what are called cognitive distortions. And if you look under Canvas, you will see a list of cognitive distortions. Cognitive distortions were created by Aaron Beck, who we all know is the founder of cognitive behavioral therapy. And he says that unipolar depression is produced by a combination of maladaptive attitudes, cognitive triads, errors in thinking, and automatic thoughts. Cognitive triad, just so you know, is a negative view of experiences, oneself, and the future. These things lead or can be connected to cognitive distortions, where these cognitive distortions, i.e., stinking thinking, can lead to people feeling a certain way, which lead them to engage or disengage via their behaviors. Psychologist Slegman learned helplessness theory states that depression occurs when people feel a loss of control over life reinforcements. So when they are not when they are not fulfilling their life goals or their duties within their life, that they have internal causes, global causes, and a lack of stability in their life, which can lead them to engage in depressive thought patterns or cognitive distortions, which then can lead them to experience sadness or even depressive feelings, which then lead them to not engage or disengage from the world. So, how depressed parents and their children actually interact? So to there was a there were two studies that led to figure 7.2, and that's from the information from Princeton survey research associates in 1996 and Weissman and colleagues in 2016. And they found that depressed parents are less likely than non-depressed parents to play with, hug, read to or sing to their young children each day, or to employ the same routine each day. Depressed parents are also more likely to get frustrated with their children on a daily basis. These problematic interactions may help explain the repeated research findings that children of depressed parents are more likely than other children to have emotional, cognitive, and or behavioral difficulties as they are maturing and aging. Let's talk for a second about learned helplessness. So Beck theorizes that there's four interrelated cognitive components that are combined to produce unipolar depression. Maladaptive attitudes, again, these are self-defeating attitudes that are developed during childhood. They cause upsetting situations later in life and can trigger an extended round of negative thinking. The cognitive triad, again, this is where individuals repeatedly interpret their experiences, themselves, and their futures in negative ways that lead them to feel depressed. We also have errors in thinking, which are arbitrary inferences and minimization of the positive and magnification of the negative, and also automatic thoughts. And these are a steady train of unpleasant thoughts that suggest inadequacy and hopelessness. So, from that, Sliegelman says that depression occurs when people believe they have no control over their life reinforcements and they assume responsibility for this helpless state. So, these maladaptive attitudes, the cognitive triad, the errors in thinking, then become automatic thoughts, and that they constantly are badgering themselves and putting themselves down, believing that the state that they're in is one that will never change, and they may be helpless in this situation. Therefore, it can lead to depression. We also have this view called the attribution helplessness theory. So, Rubenstein and colleagues built off of Sliegelman's perspective of learned helplessness to say that people question themselves when events are beyond of their control. So, when there's some internal, global, and stable cause that leads them to question themselves and take responsibility for situations that are outside of their control, they can become depressed. An attribution, to be more specific, unstable, or external causes, will equal less likelihood of learned helplessness and depression. So, when they're able to look at these causes and not take responsibility, they will not act helpless and they will reduce the chances of developing depression. Liu and colleagues also found that attributions that produce hopelessness can also lead to depression. The family social perspective says that there may be a decline in social rewards, which impact depression. So many sociocultural theorists propose that unipolar depression can be greatly influenced by the social context that surround people. The belief is supported by the findings that depression is often triggered by outside stressors. The connections between declining social rewards and depression, as discussed by behaviorists, can be a two-way street. Depressed people often display social deficits that make other people uncomfortable and may cause them to avoid depressed individual. This can then lead to decreased social contact and a further deterioration of social skills. Consistent with these findings is that depression has been tied repeatedly to the unavailability of social supports, such as that found in a happy marriage. People who are separated or divorced display 3 times the depression rate of married or widowed persons and double the rate of people who have never been married. There's a high correlation between level of marital conflict and degree of sadness that's particularly strong among those who are clinically depressed. People who are isolated and without intimacy are particularly likely to become depressed, especially in times of stress. So, what we see here in this image is an fMRI, a functional MRI image. So, there's a widely used design called Cyberball. And what we see here is that someone is in a functional MRI scanner and is told in a falsified way that they're playing a game of cyber catch with 2 players in other rooms. As the other players increasingly exclude the participant from the three-way catch, the functional MRI records show parts of their brain that are being affected. As shown in these brain scans, Subregions of the anterior cingulate cortex on the left and the prefrontal cortex on the right are key structures in the depression related brain circuit. And these areas become activated during this lab induced social exclusion, just as they do in cases of clinical depression. Then we have a multicultural perspective. So they say that there's a strong link that exists between gender and depression. So across various cultures, women are twice as likely as men to receive a diagnosis of unipolar depression. And women with depression have an earlier age of onset, have more frequent and longer lasting depressive episodes, and respond less successfully to treatment. So, how do we explain this? Well, there's a couple of things. The artifact theory holds that women and men are equally prone to depression, but that clinicians often fail to detect depression in men. The hormone explanation holds that hormone changes trigger depression in many women. The life stress theory suggests that women in our society experience more stress than men do. The bodily dissatisfaction explanation states that females in Western society are taught, almost from birth, but particularly during adolescence, to seek a low body weight and slender body shape, goals that can be unreasonable, unhealthy, and often unattainable. The lack of control theory draws on the learned helplessness research and proposes that women may be prone to depression because they feel less control than men over their lives. And finally, we look at rumination theory. Research reveals that women are more likely than men to ruminate when their mood darkens, perhaps making them more vulnerable to the onset of clinical depression. So let's look at this. For many people, especially with PDD, or PMDD rather, they may find that it's deja vu. So in the DSM-4, which was created and implemented in the 1990s, there were controversies about the inclusion of PMDD as an actual category. And the concern was about the lack of data and pathologizing severe PMS cases. But it ended up becoming listed as a pattern in the DSM-4 appendix. Now, in the DSM 5, it's included as a depressive disorder category. But is it enough? Some people say yes, and some people say no. Building on this multicultural perspective is that depression can be found worldwide, and core symptoms have been reported. These core symptoms include sadness, joylessness, tension, lack of energy, loss of interest, loss of the ability to concentrate, ideas of insufficiency, and thoughts of suicide. And the precise picture of depression will vary from country to country. But depressed people in non Western countries are more likely to be troubled by physical symptoms of depression, whereas Westernized countries take on more of a cognitive characteristic. There are very few differences in depression symptoms or overall rate of depression among different members of the United States racial or ethnic groups. There's a striking difference between ethnic and racial groups in the recurrence of depression. And there's an uneven distribution of depression within some minority groups. You're typically going to find, as we will discuss in class, that these differences do make a major difference. And they are also similar, not only in different racial and ethnic groups, it also can coincide with age. So, let's look at the developmental pathology perspective. This says that unipolar depression is caused by a combination of factors. This is based on genetics, especially if they were influenced by significant trauma early in life, the magnitude and timing of negative factors, and resiliency linked to moderate and manageable adversities through childhood. And that these three factors unfold and intersect as they occur during one's development, which can lead later in life to depression. Now let's shift to bipolar disorders. So, unlike those experiencing depression, people in a state of mania typically experience dramatic and inappropriate rises in mood. So, some emotional symptoms of mania include active, powerful emotions in search of an outlet. Motivational symptoms can be a need for constant excitement, involvement, and companionship. Behavioral symptoms include someone who's very active and they move quickly, they can talk loudly or even rapidly, and that they're extremely flamboyant. Cognitive symptoms can include showing poor judgment or the inability to plan. They have trouble with remaining coherent, and they may not be in touch with reality. Physical symptoms include a high energy level, often in the presence of little or no rest. So there's two different kinds of bipolar disorder, bipolar 1 and bipolar 2. Worldwide, about 1 to 2.5% of adults have bipolar disorder at any given time in their life, um, or at any given time, I should say, and 4% have it in at least some point in their life. And there's really no gender differences, but there are higher rates in lower income populations. So, what is a manic episode? So, for 1 week or more, the person has to display a continual, abnormal, inflated, unrestrained, or irritable mood, as well as continually heightened energy or activity for most of every day. And they must have three of the following symptoms: grandiosity, overblown self esteem, reduced need for sleep, rapidly shifting ideas, the sense that one's thoughts are moving very fast, attention pulled in many directions, heightened activity or heightened agitation, and excessive pursuit of risky and potentially problematic activities. And the manic episode has to significantly distress or impair someone's activities of daily living and their daily life. So, what's the difference between bipolar 1 and 2? So, bipolar 2 is where there's the occurrence of a manic episode, and hypomanic or major depressive episodes may precede or follow the manic episode. Whereas in bipolar 2, there's the presence or history of major depressive episodes as well as hypomanic episodes, but there's no history of a manic episode itself. When we talk about cyclomythic disorder, this is where you have numerous periods of hypomanic symptoms and mild depressive symptoms, and they need to continue for 2 or more years with normal moods for several days or weeks in between. With cyclomythic disorder, it's typically the same depending on gender, and it may evolve into bipolar 1 or bipolar 2 disorder. So, how do we diagnose bipolar disorders? Well, to think for a second, the onset usually occurs between the ages of 15 and 44 years of age. In most cases, the manic and depressive episodes eventually subside, but only come back and reoccur at a later point in time. So, when we are looking at the diagnosis, especially if someone doesn't have treatment, the mood episodes tend to recur for people with either type of bipolar disorder. So, 4 or more episodes within a 1 year period are classified as what's called cycling. Cycling is where you go from some type of mania to some type of depression, and then you continue that cycle. Depression tends to be experienced more than mania and can last a lot longer than mania itself. And generally, when episodes occur, these rapid cycling episodes, the intervening periods of normality grow shorter and shorter. So, what causes bipolar disorders? So, in the first half of the 20th century, the search for the causes of bipolar disorders made very little progress. But over the last 50 to 70 years, biological research has produced some promising clues. And they've come to realize that neurotransmitter activity, ion activity, brain structure, and genetic factors can influence the causation of bipolar disorders. So, when we look at neurotransmitter activity, they have found that there's a relationship between low norepinephrine and unipolar depression, right? So, early researchers expected to find the link between high norepinephrine levels and mania. And this theory is supported by some research studies. Because serotonin activity often parallels norepinephrine activity in unipolar depression, theorists expected that mania would also be related to high serotonin activity. Although no relationship with high serotonin has been found, bipolar disorder may be linked to low serotonin activity, which seems contradictory. This apparent contradiction is addressed by the permissive theory about mood disorders. Low serotonin may essentially open the door to a mood disorder and permit norepinephrine activity to define the particular form the disorder will take. So, Low serotonin plus low norepinephrine equals depression, but low serotonin plus high norepinephrine will equal mania. So if someone has low serotonin and they're fluctuating with norepinephrine, when they're low, they're in depression. When norepinephrine's high, they're in mania. And once these norepinephrine levels shift, that's called a cycle. When we look at ion activity, ions, which are needed to send incoming messages to nerve endings, may be improperly transported through the cells of individuals with bipolar disorder. Some theorists believe that irregularities in the transport of these ions cause neurons to fire too easily, which may be related to mania, or stubbornly resist firing, which leads to depression. And there's some research that can support this theory. When we look at brain structure, brain imaging and postmortem studies have identified a number of abnormal brain structures in people with bipolar disorder. In particular, the basal ganglia and the cerebellum are not as developed. It's not clear what role these structural abnormalities play, but they recognize that these abnormalities exist. Then we look at genetic factors. So there are theorists that believe that people inherit a biological predisposition to develop bipolar disorders. So the family pedigree study supports this theory that identical or monozygotic twins are 40% more likely to develop a bipolar disorder. Fraternal or dizygotic twins and siblings are 5 to 10% more likely to develop a bipolar disorder. The general population is between 1 and 2.5%. We also look at other genetic factors too. So they've conducted, researchers, I should say, have conducted genetic linkages um, to identify possible patterns of inheritance. Other researchers are using techniques from molecular biology to further examine genetic patterns in large families. Such wide ranging findings suggest that a number of genetic abnormalities probably combine to help bring about bipolar disorders. So, making sense of all of this, when we look at unipolar depression, we find that there are biological factors, a reduction of positive reinforcement, cognitive distortions or negative thinking or stinking thinking patterns, perception of helplessness, life stressors that occur, and multiple sociocultural influences. In bipolar depression, we often find that there's more of a biological abnormality, which may be inherited and occur developmentally or is triggered by stress. I hope that this was helpful for you. As always, if you have any questions, comments, or concerns, please feel free to reach out to me via email. Also, don't forget, in the description box below is this week's extra credit question. All you need to do is answer it in the comments, take a screenshot, and upload it to Canvas for up to 1 point added to your final grade. Don't forget it's due by Sunday at 11:59 p.m. I hope that you have a great day and be well.